Dr. Reem and Dr. Mohammed al-Mohammadi and the organizing committee for giving me the opportunity to share this lecture here. And I can see a lot of people which from my hospital and other hospital knowing them. So in this case, Dr. Nahla have covered a lot from my lecture. We will be covering today lectures of cases, covering the cases of MPN and MPN-MDS overlap on the highlight of the new WHO edition. So my objectives here is to see understanding the key dilemmas and pitfall encounter in diagnosis of myeloproliferative and MDS, including related accurate classification and differentiation from other hematological disorder and interpretation of the bone marrow morphology, discuss the updated diagnostic criteria and changes in the MPN and MDS in the 5th edition, and emphasizing in the incorporation of the molecular and the genetic marker for the precise diagnosis, and develop with each other a strategy, so how to skip any dilemmas or pitfall that we can found in the MPN-MDS diagnosis by incorporation the multidisciplinary collaboration between different utilization of different ancillary techniques like flow cytometry, cytogenetics, molecular testing especially have a very big role in this 5th edition. The most important is that in the 5th edition, as seen by Dr. Nahla earlier, that they put in each classification with an essential criteria and together with a desirable criteria. They put every case, every diagnosis with a specific molecular and cytogenetic features, not meeting any other subtype criteria, and having a different pathological and clinical features, which is approved by at least 2 peer review publications. The most important is the inclusion of the clonal hematopoiesis, which is very important as a precursor lesion for myeloid malignancies. The clonal hematopoiesis is referred to the presence of population of cell derived from the hematopoietic stem cell, harboring somatic mutation and leading to enhanced cellular proliferation under positive clonal selection pressure. Most frequently, including the epigenetic regulator gene that we can see now most commonly by the NGS, and in the absence of unexplained cytopenia, hematological cancer, or other clonal disorder. Under clonal hematopoiesis, we found the intermediate undetermined potential, which specifically to the genetic mutation with myeloid malignancies, and the clonal cytopenia, which included, again, with cytopenia, both with no previous or underlying malignancy, myeloid malignancies, or other hematological or non-hematological cases. Here is the WHO cover, and we can see some of the removed, some are changes, some is added. Our first case, and I want to share with people if you have comment, kindly do. We received the patient with CML as a referral hospital, already diagnosed as a CML case with positive PCR ABR, and he started to this therapy. His bone marrow was done for complete CML workup. As you can see, the peripheral blood shows the left shifted with the 2 peaks of neutrophils on the myelocyte and with no blast seen. But on checking on the aspirate, we can see almost 8 to 10% blast cell with eosinophilia, basophilia, and the characteristic dwarfing. Kindly note that cases of MPN-HU1 has a specific megakaryocytic picture or morphology. For the CML, the cells are always smaller in size than the normal, and they have hypolipated nucleus, so we call it a dwarf MEG. In this case, 8 to 10, and upon the acute leukemia orientation tube, we found that these 8% are lymphoid blasts. So by now, each case, one of the pitfalls that by now, not as before, each case of CML upon introducing to the hospitals, an acute leukemia orientation tube has to be done so that exclusion of lymphoid blastic crisis on top of CML as a presence of real confirmed lymphoblast in the peripheral blood or bone marrow, even less than 10 will be considered as lymphoid blastic crisis on top of CML. The second case is again myeloid CML case, again presented to our hospital with a PCR-able positive for complete workup. You can see there is almost 11% blast, and again with the shifted maturation, eosinophilia and basophilia. On doing the bone marrow biopsy, the aspirate almost was low cellular. As you can see here, the bone marrow biopsy is completely hypocellular with streaming. There is diffuse and dense increase in reticulin deposition, almost streaming of the marrow and the obscuring the cellular morphology of the cell. As you can see here, there's clusters of the small megakaryocyte, the characteristic of the CML. Upon doing the reticulin, it is an MF3, the CD61 confirmed the small nature of the CML, and the CD34 didn't show increase in blast cell even with the presence of this fibrosis. So for these cases, as Dr. Nahla said, they omitted the case of accelerated phase, but putting instead the addition of features with increased risk of disease progression. These are the ELIT score, the increase of the blast up to 1019, increase in basophil, additional chromosomal abnormality, and cluster of megakaryocyte. So for here, we find in this case, we find the two أنا بعمل حاجة غلط. أنا كده ماشية صح. Can you help me, please? Go. This is forward or backward. أنا راجع كده ورا. راجع كده راجع خلاص. Okay. Okay. Sorry. Sorry for the interruption. Now, for our case, for this case, we find that we have two of the accelerated phase of this disease. The third is a case of, we have this patient at our hospital. The patient was diagnosed as a case of MPN at 2012-2013 because she has sequentially DVT and ischemic stroke, followed by requesting JAK and definitely PNH. Her JAK2 was positive and PNH released negative. On checking on the report received, it was normal bone marrow. So her clinician by now, after 12 years of taking apixaban and following her as a case of MPN, he wanted from us to evaluate her bone marrow. On checking on the peripheral blood, she was normalized, almost normalized of the peripheral blood, and her bone marrow aspirate was also normal with tri-lineage hematopoiesis, no increase in blast cell, no fibrosis, and nothing. The age-adjusted cellularity is very good and nothing changed. For this cases are that the patient has a normal cellular marrow showing tri-lineage hematopoiesis with no evidence of dysplasia or infiltration. Correlation with other major criteria is mandatory for establishing a diagnosis of MPN. For follow-up until sufficient evidence of more precise diagnosis. Kindly, whenever you have a case of JAK2 positive, you cannot mark the patient as MPN. Patient as currently marked as MPN with a major and a minor criteria. Otherwise, this criteria is fulfilled, don't mark him as an MPN. JAK2 mutation can be seen in the general healthy population with a prevalence of 0.2. Yes, it is associated with increased morbidity and mortality, and also with more to be develop an MPN in another situation later on in life, but unless you find the criteria, kindly don't match the patient as an MPN. For this patient, the genetic risk for clotting factor as factor V, homocysteine, folic acid deficiency, and proper history for hormone as birth control pills, hormonal replacement therapy, or inflammatory bowel disease would be much appropriate than putting the patient as an M2. Here, another patient is a case of 57 years, came to our hospital again with JAK2 positive, but this was diagnosed as essential thrombocythemia with treatment hydroxyurea and apixaban due to DVT. This patient developed over time increase in the hematocrit level, reaching from 49 to 51, and each time there's increase in hematocrit. They do phlebotomy and so on. He put it in bone marrow with no change, so he came to our hospital to check. The last phlebotomy was on the 23rd of August 2023, and this is his peripheral blood. His peripheral blood, definitely you can see the hemoglobin is 13, but because of the phlebotomy, the bone marrow aspirate show high normocellular or hypercellular marrow with active tri-lineage hematopoiesis, megakaryocytic hyperplasia with a background of platelet sheets. Again, the megs are variable with frequent large hyperlobated nuclear lobes. Again, ET have a specific morphological features in cases of ET. It has to be large, variable, hyperlobated, cloud-like, as if it is an onion. So this is the characteristic picture of megakaryocyte. As you can see here, a lot of a lot of megakaryocyte can be seen. Okay, I'm here. Okay. انت شفتوا الميجاكاريوسايت؟ خلاص أنا مش عارفة أعمل إيه بصراحة. A lot, we can see it here. A lot of megakaryocyte here proved by 61 and no increase in blood cell. So his serum erythropoietin level was tested of 7.6. Currently, his bone marrow shows increased age-adjusted cellularity with megakaryocytic, granulocytic hyperplasia, no fibrosis, positive JAK2. So the 3 criteria of polycythemia vera is already fulfilled. So this patient will be put as a case of progression of essential thrombocythemia to polycythemia vera. This progression has been reported, and as a polycythemia vera is a more serious disease than cases of essential thrombocytosis. And here, the most important is the JAK2 allele burden. Most of our hospitals have the positive negative, but JAK2 allele burden is very important to differentiate between different cases of MPN. Our 5th case is a case of 47 years old, referred to our hospital with low-grade fever, weight loss, fatigue, cough, edema of his eyelids, angioedema. And upon his investigation, he was suffering marked eosinophilia with increase in vitamin B12 and mild hepatosplenomegaly. His PCR-ABL was negative, and he was given to us for bone marrow evaluation. As you can see, his peripheral blood shows marked eosinophilia with an absolute count of more than 5,000, with abnormal morphology and 2% blood circulating in the peripheral blood and mild thrombocytopenia. If you check the bone marrow aspirate and biopsy, giving the same picture with increased eosinophilic precursor showing abnormal granulation, hypogranulation, cytoplasmic vacuoles, and abnormal nuclear lobation. Okay, there's also a megakaryocytic dysplasia, and the blood cell was almost 4 to 5%. We added this patient as a case of chronic eosinophilia, chronic eosinophilic leukemia. His AML panel was negative, JAK2 negative, but upon doing the mutation, clonal hematopoiesis again, the driver mutation XSL1 was positive, confirming our diagnosis of chronic eosinophilic leukemia as Dr. Nalaso. So this case, chronic eosinophilic leukemia has much changes. Eosinophil with an interval less than only 4 weeks, evidence of clonality which cannot be replaced by increasing the blood cell at the earlier one, and abnormal bone marrow morphology and exclusion of other cases. By this way, we can definitely differentiate between chronic eosinophilic leukemia and other incidents of eosinophilia. And by this, there is no need for chronic eosinophilia if we will not otherwise specify, so we omitted this. I added here a diagnostic scheme for all of you to be used for in all hospitals, how to reach a diagnosis of eosinophilia eosinophilia, differentiating eosinophilia due to reactive, myeloid, and at the end, the clonality and abnormal bone marrow morphology, if it is present, chronic eosinophilic leukemia, if it is not present. So if it is an organ damage, it will be hypereosinophilic syndrome. Without organ damage, it will be hypereosinophilia of uncertain significance. Case 6, it's a 57 years old female patient. It's our patient long time ago from when we started the transplantation in multiple myeloma. She, from the first, which have second autostem cell in 2016, by time she developed severe cytopenia, pancytopenia. I think the referrals here will be remembered this case for, and a little bit the MBAC increased with repeated the bone marrow and the PET scan. There is no negative relapse. So suggestion of the bone marrow. The bone marrow show marked neutropenia of 0.03, and again up-articulated and hemodiluted aspirate with left-shifted maturation, as the patient was GCSF for day after day with no response for a year. So when we check the bone marrow biopsy, what we can see in the bone marrow biopsy is marked fibrosis, osteosclerosis, and you can see كثير والله لا ارجع كده. We find okay, marked fibrosis, there's marked fibrosis and new bone formation, osteosclerosis, almost the bone marrow spaces is blocked due to the fibrosis. Here there is the few areas which show cells showing serous degeneration and stromal edema. The CD138, you have to exclude relapse, was almost 8 to 10% with polyclonal pattern predominance of kappa. Marked fibrosis. Trichromastrain is grade of 3, interconnecting new bone formation, blocking of the intertrabecular spaces. So there's extensive interconnecting measure of bone. So the patient for me was an stage of myeloproliferative PMF. What about the dysplasia and this, what we can see? What we can see in a dysplasia at some time cases with PMF, at the end with the transformation and the progression, dysplastic features is accepted to be seen. Again, we have done the multiplex PCR and the sequential JAK2 calreticulin. The patient was negative, but it was positive for TET2, and again, the driver mutation. Dr. Nala covered the myelodysplastic syndrome, the new criteria. So, and this is a new article coming from Blood, which have a comparative study between 2006, 2022, and the International Consortium for the MDS to see the different the difference between them. The most important, as we said before, the softening between the MDS and acute myeloid leukemia. It's about case by case rather than and tailored treatment rather than to put it as a standard. This patient, we received him as a long-standing history of thrombocytopenia, not responding to steroid. His peripheral blood show mild left shift with mild leukopenia and neutropenia. His neutrophils show nuclear hypo and hypersegmentation, as you can see here. Okay. His bone marrow showed dry tap. As you can see here, the biopsy consists of single core. It is markedly hypercellular bone marrow, increased age-adjusted cellularity, marked megakaryocytic hyperplasia with atipia and large megakaryocyte with hyperlobation and megakaryocyte cluster seen. There is paratrabecular localization, as you can remember. Cases of MBF, the real presence of the megakaryocyte must be seen in the middle of the intertrabecular area, but in cases of PMF, we can see the megakaryocyte in clusters and near the trabeculae, which is not the care, which is endosteal translocation of the megakaryocyte with tight clusters and loose clusters. So as you can see here, the CD61, the CD34 is not increased, and also increase in the myelofibrosis. So in these cases, definitely we have to exclude the nutritional profile and any the other cases which included like Philadelphia, BDGFR, and whatever. But this case, she has fibrosis and she have an MDS, okay? But again, as a new criteria, if we have a MDS with fibrosis, it must have an increased blast percentage. So I added the patient as MDS with low blast, and I put it associated with fibrosis. When I returned back, I found it was in the literature. Some cases of MDS with low blast can be with mild fibrosis, but my concern more was, or my heart was with myelodysplastic, myeloproliferative neoplasm, not otherwise specified. Why? Because in the peripheral blood, I can see the two things. I can see neutropenia and left shift. This is not a combination that we can see it in MDS. MDS, I can see pancytopenia, but I cannot see left shift, okay? So we have dysplastic features and cluster and endosteal translocation. This combination, again, cannot be seen in cases of MDS. MDS have a dysplastic micromegakaryocyte, but it doesn't have clustering, endosteal translocation. This is a myeloproliferative morphology. For this case, again, my heart was with the MDS, MPN, not otherwise specified. So mutation, as I've said, the mutation, especially the NXL1, DMT3, I know most of us doesn't have it, but I believe it is really important nowadays. So we added the patient as hypercellular bone marrow with triheinous hematopoiesis, megakaryocytic proliferation. This megakaryopoiesis and fibrosis, the patient is mostly MDS with low blast associated with fibrosis versus myelodysplastic myeloproliferative neoplasm, which we prefer at that time. The eighth case is a 58 years old female patient was again referred to us for an MDS. As you can see, she has moderate leukopenia and neutropenia and 2% circulating blast. Hemodiluted aspirate with only 4% blast. This is the blast cells. So when we do the bone marrow biopsy, again, you can, the bone marrow biopsy, this is the same, yeah. The bone marrow biopsy again show, as you can see here, there is a lot of clustering of the megakaryocyte, and there is this plastic megakaryocyte. So the 34 is not increased, it's almost 5%. And the megakaryocyte here was positive to CD61. The fibrosis was an MF1, so I added this patient as an MDS with increased blast type 1, as there is a category 2 to 4% or 2 to 4% blast in the peripheral blood. Because of the or 2 to 4%, I added as an MPS with increased blast type 1. Unfortunately, after 1 year, this patient came to us with blast count of 33 in the aspirate. Transformed it to acute myeloid leukemia, confirmed by flow cytometry. And again, the hypercellular bone marrow, but you can see here the diffuse infiltration with blast cell, and the atypic megakaryocyte is hardly seen. But the strange with the CD61, the strange that we found it if we send it to Mayo Clinic and we found it as MECOM. So this patient from the start could be less than 20% could be treated as an AML because of the MECOM abnormality rearrangement that we said. And again, the beautiful thing about the new WHO putting an essential criteria and desirable criteria for each. The case number 9, you have 67 years old male, MDS.
3 minutes.
2 minutes?
3 minutes.
3 minutes, okay. So this is an interesting case. A lot of blast seen, and there is a neutrophil, showed defective segmentation, and on flow cytometry, this patient showed right shifted with increased neutrophil, increased fibrosis. So this patient added as a primary myelofibrosis fibrotic state. Again, after a few years, 8 months, he developed to blast. The 10th is a case of neutrophil increase in the peripheral blood, persistent by cytopenia with mild shifted. This patient, we added it as MDS MPN with neutrophil due to the overlapping of pancytopenia and megakaryocytic dysplasia. Again, we added the cytopenia, the definition that I added before. So this patient was MDS MPN with neutrophil. Thank God it came up with a setup confirming our diagnosis of MDS MPN neutrophil rather than MDS MPN, not otherwise specified. And this is my last. It is a case of mixed phenotype acute leukemia. Kindly, whenever you have a case of mixed phenotype acute leukemia, don't depend on only one ancillary test. You have to do 2 ways. Anything, flow cytometry, immunohistochemistry, cytochemistry, a single thing, it is not appropriate. This patient referred to us as a mixed phenotype acute leukemia, positive MBO and positive 13, 33, and 1117. On doing the flow cytometry, the patient, here's the patient, infiltration was blast. So I do respect every lab. So because the flow cytometry was straightforward, but rather than it was straightforward for me, no MPO, as I told you that I have to do in each case 2 things to confirm if it is positive or not. So we added an MBO on the section, and as you can see, it was showing interstitial positivity, yet you see the infiltration of the blast. It is fully infiltrated, and the CD3 is fully infiltrated. So for me, interstitial positivity of MBO is against that it is positivity, because this is a residual myeloid. The blasts tend to adhere together and coalesce together rather than to be separated away from each other. So as you can see here, the blast, this patient was an ATP, ALL. We released it as an ATP ALL, and again, I'm asking from everyone to do 2 types of MBO, and the most important, what we have been added with the WHO, that each of the marker that we use, it has to reach 50% positivity from the normal counterpart. As a 19, have to reach 50% of the normal B. As a MBO, we have to reach 50% of the neutrophil, residual neutrophil. Or we have to do like a validation for the cutoff positivity of the MBO. Rather than to put the patient if has non-specific binding because of the cytoplasmic nature of MBO, and there's a lot and the huge number that we're entering at the diagnostic. So a lot of non-specific binding you can see at that time. So please do a cutoff value by validation, or if you do even spike their case with a neutrophil, to check the level of the neutrophil. The blast cell has to reach 50% of the MBO. Earlier also for the B, for the T, each of them have to be 50% of the normal counterpart. You can find a little bit of MBO and you say it's positive. And never do it with only one thing. You have to do it with 2 ancillary testing, either flow cytometry, immunohistochemistry, cytochemistry, together with the molecular and cytogenetic can lead you. But for us morphologists, we have to do that as a pitfall from putting the patient as mixed phenotype acute leukemia, which has a completely different treatment than ETP. Thank you all audience for taking from your time to listen, and thank you Dr. Reem, Dr. Mona, Dr. Muhammad, and all the attendees. Thank you very much.